Thank you, Dr. Abdullah, for the invitation. And as you said, 10 minutes to talk about mitral and tricuspid, it will be horror, but we will start. So, as we know, mitral and tricuspid valve disease is very common in the elderly population. It's a very, very important problem. Mitral regurgitation, if the patient develops severe mitral regurgitation, so the prognosis is very bad, the mortality increase. And if we talk about the mitral regurgitation, it's not only MR or mitral regurgitation. We have to differentiate different phenotypes. Is it primary, the problem is the valve, or it is secondary to structural problem in the ventricle or the atrium? So why should we differentiate? Because the modality of treatment is different. And one issue also is the mechanism of mitral regurgitation. It's not enough to say I have a patient with severe mitral regurgitation, because the mechanism of mitral regurgitation has also an influence on the modality of treatment. Is it annular dilatation or prolapse or restrictive movement, most probably from the posterior mitral leaflet? Okay, degenerative primary mitral regurgitation, it's a problem of the valve. The ventricle is good, so either I have myxomatous infiltration, some prolapse, or chordal rupture. Echo, of course, is very important for the diagnosis, and not only 2D, we need 3D to identify the mechanism of mitral regurgitation. Good. Guidelines, if I have a symptomatic severe mitral regurgitation, operable, go to surgery. If he's not operable, go to interventional treatment like transcatheter edge-to-edge repair. About asymptomatic patients, I don't know if I have a patient with severe mitral valve prolapse and severe mitral regurgitation, he tells me he's asymptomatic. Why should I wait? Because waiting will not help the patient, but the guidelines tells we have some parameters to consider, like the ejection fraction, development of atrial fibrillation, pulmonary hypertension, to justify the treatment. Okay, the new guidelines, the European 2025, we have a class 1 indication, of course, as we said, symptomatic severe mitral regurgitation, acceptable surgical risk, go to surgery. If the risk is high, so we can go to the interventional treatment. And it's anatomy and risk. They drive our decision how to treat these patients. Why the anatomy? Because not all the patients are suitable, for example, for transcatheter edge-to-edge repair. And we have, since a couple of years, other modalities also. Okay, the secondary mitral regurgitation, we don't have here the mitral valve, the problem. The problem is structure, is the ventricle. And we have, since 2 or 3 years, the differentiation between ventricular and atrial. What is the cause of the secondary mitral regurgitation? Because atrial fibrillation, we have heard today the topic from electrophysiology point of view. Atrial fibrillation is also a very bad disease for the atria. And of course, if I have ventricular mitral regurgitation or atrial mitral regurgitation, so also it has an influence on the treatment of the patient. So we have to classify the phenotype of the mitral regurgitation, and accordingly, so ventricular mitral regurgitation, if I have a patient with very bad ejection fraction severe mitral regurgitation, I have to start first treatment of the ventricle, because the problem is not the mitral regurgitation, it is a secondary problem. If I fail, so I go to treat the mitral regurgitation. And if I have a patient with chronic atrial fibrillation, big atria, and atrial fibrillation, so I can offer him treatment of his atrial fibrillation, and if the problem stays, so, and he's operable, I send him to surgery. If he's not operable, so I can do transcatheter edge-to-edge for him. So, like I said, we have criteria that favors the interventional treatment, and in patients with secondary ventricular mitral regurgitation, if I have a very bad ejection fraction and end stage, so it is very late also to treat this patient, and we have to think about left ventricular assist device or HDX, heart transplantation. What are the options we have to treat mitral regurgitation? We know all transcatheter edge-to-edge, but we have a lot of procedures, starting the leaflets, the annulus, the chordae, and if I have multiple problems, we have also the mitral valve replacement. Mitral clip, I think we know it, and it's based on the Alfieri technique from the cardiac surgeons, and we have 2 established systems, others coming, and the idea is to reduce the coaptation defect. And of course, as we started very early, we had to respect some anatomical criteria, like the Everest mentioned in the Everest trial, but now we are more pragmatic to treat these patients. For example, this patient with mitral valve prolapse, good, treated good, and if we have also functional mitral regurgitation, mostly it's a central jet, also we can get a good result. And we have good trials that supported also our treatment modality with transcatheter edge-to-edge repair. One of the landmark studies was the COAPT trial, which showed us a very, very good survival benefit if we treat these patients. And also in comparison to the surgical repair in patients who shows high risk, also the transcatheter edge-to-edge repair has a good result. Okay, if I cannot repair the valve, what should I do? So I have to replace it, because if we see this valve, if somebody thinks about edge-to-edge repair, he will maybe need 10 hours to treat this patient. At the end, it will be a big failure. So we have a lot of systems. One of them is the M valve, now CE-mark, and also the Tendyne, which is transapical, transfemoral will come, can also treat such patients. Of course, the criteria to select these patients is very strict. Also, we have some valves that are coming in the next future, also treating the patients with a valve. Good. Now, I have 3 minutes for the tricuspid valve. Can you add, please, 2.5 minutes or 3 minutes? Tricuspid valve is more complex than mitral valve because we didn't treat the tricuspid valve for years. We gave only Lasix, and the patients developed renal failure, multi-organ failure, and then died after that, but died after a long suffering. Okay, also phenotypes. Is it primary tricuspid regurgitation or secondary? Most of the patients we see, they have secondary tricuspid regurgitation. So the problem is not the tricuspid regurgitation. The problem is the basic disease, which mostly left-sided. HFpEF, I don't know how to treat HFpEF, or ischemic cardiomyopathy, or. So we know all these pictures. I started my career with doing right heart catheterization for every patient with dyspnea. And of course, the diagnosed tricuspid regurgitation was also angiographically. We did a lot of angio. Okay, echo, of course, is very important. So tricuspid regurgitation, it's a lethal disease. It is a lethal disease, yeah? And when it develops, we have to make something. But first, we have to treat the primary disease. Okay, tricuspid valve is very complex. We say 3 leaflets, maybe sometimes we see 5 leaflets. The challenges are very, very big because the patients are coming very late. We have a very big coaptation defects, and we have also other problems that are not treated, and the patients have a lot of comorbidities, and they are sicker than the mitral valve patients. Okay, as I said, it's a complex group of patients, and we do not depend only, I think Dr. Hani Sapur told right heart catheterization. It's very important for these patients because, like he said, we do not depend only on the echo parameter. We have to do right heart catheterization because there are parameters shows us we cannot treat this patient with interventional or surgical procedures. Okay, the mechanism of tricuspid regurgitation, mostly ring dilatation, but sometimes we have restrictive also leaflets. So the triclip, it's like the mitral clip, but in the tricuspid position. So as we started to treat the patients with a mitral system in the tricuspid position, and we said, okay, it's functioning good, and we have after that the triclip. The imaging is very important, and according to some anatomical criteria, we can have very good results. Okay, very important landmark trial is the Triluminate. Said we have we help these patients. We do not prolong their life, but we help them to have a better life quality. Okay, as I said, the patient selection for tricuspid valve interventions, it's depending on patient's factors and anatomical factors, hemodynamic factors. It's not only treating the valve. And we have a lot of anatomical criteria to respect to treat the patients with this technology. Okay, we know with the repair, I cannot have 100% reduction of the TR. We have 1/3 of the patients, they have some residual TR. And we have some predictors for this, like large coaptation defects, and therefore we needed to replace the valve because we know replacement is better than repair if the repair is bad. So we have the EVOQUE from Edwards, now CE mark, good results from the TRISCEND trial, and we have also coming soon also the cardio valves. It's very nice to implant and good also result. Now we have these anatomical criteria, how to choose which patient can benefit from which procedure. 1 minute. 1 minute. على طول يعني 5 درهم وانا ماشي. تمام؟ Okay, good guidelines. The tricuspid valve intervention or percutaneous is now in the guidelines. So this is great success. And if I cannot help the patients anymore with anything, so we have some palliative procedure, which is a heterotopic valve transplantation in the vena cava. One we know is the tric valve to stents, and we have also coming soon some innovative technologies. Okay, at the end, we can help the patients when they are coming not very late, and in experienced centers, of course, we can offer therapies for all these patients. The main thing, we have to select the proper patient, the proper procedure for the proper patient. Thank you very much.
Excellent.